This program is brought to you by Emory University.
All right. Well, good morning, everybody. Happy Friday. Welcome to Fellows Conference. Today, you can see is a journal club, two presenters as per usual. Our first presenter is Dr. Khawaja. Muz is a second-year fellow in the clinical track, did his residency at Baylor, and he is going to talk to us today about the ULTIMAR-DAPT trial. Muz, take it away.
Thank you. Good morning, everybody. Thanks for joining. So I have no disclosures for this talk. So before I get to discussing the ULTIMAR-DAPT trial, which was recently published a little bit over 2 weeks ago, I'm just going to talk about acute coronary syndrome and the role of DAPT therapy and the duration of DAPT therapy, where the evidence comes from for our international guidelines, both in the European guidelines and the American guidelines. And then we'll go through the ULTIMAR-DAPT trial using a PICO format, and then we'll kind of talk about what are the big takeaways and future directions. So just kind of like a broad overview of DAPT therapy in general for ACS. So as we know, cardiovascular disease is the leading cause of mortality worldwide, with ischemic disease being the top contributor. These patients, especially specifically patients with acute coronary syndrome at high risk of death and myocardial infarction, but early revascularization, specifically with percutaneous coronary intervention involving drug-eluting stents, can drastically improve prognosis in these patients, and it's one of the cornerstones of our treatment strategies. But these patients obviously can still develop acute and long-term ischemic events and complications despite being revascularized. So that's where the role of pharmacotherapy and in particular antithrombotic therapy kind of comes in, because it's been shown to improve outcomes in these patients. But in clinical practice, we've been trying to tinker with trying to best optimize the best outcomes for these patients from a cardiovascular standpoint while avoiding the trade-off, which is higher risk of bleeding, as we know. So these antiplatelet agents are the cornerstone of our antithrombotic therapy for these patients that undergo revascularization with PCI after ACS, because they're able to prevent local as well as systemic thrombotic complications. And we've noticed that there's been a drastic evolution in antiplatelet strategy over the past several decades for a variety of reasons. We've had advancements in drug-eluting stent technologies and techniques. We've had development of newer antiplatelet drugs and agents and targeted therapies. We also have a better understanding of some of the prognostic implications that in terms of bleeding complications for some of these patients. And we've also had improvements in terms of profiling which patients are high risk for bleeding complications as well as for ischemic events. So there's been a lot of changes, and our guidelines are slowly starting to reflect some of these changes, but it's important to note that the data has been trending towards a change in how we view DAPT therapy after ACS. This is kind of a busy slide here, but I included it just to kind of depict that, in patients with acute coronary syndrome, where you have an arterial thrombus formation, it's important to recognize that it's a very complicated, dynamic pathological process. And platelets have a key role in it, because there's an important crosstalk between platelets and the hemostatic pathway as well as inflammatory pathways. And so all these complex interactions contribute to the development of thrombotic complications when a plaque destabilizes, with plaque rupture or erosion typically for these patients that we see with ACS. So as we know, when this plaque is disrupted, you have the activation of the coagulation cascade, and platelets can then aggregate to form subocclusive or occlusive thrombus, which contributes to these end-STEMI and STEMI patients. But it's also important to recognize that you can have repeated phenomenon of plaque injury and healing with contained thrombus formation over time. This is repeated cycles of this can actually promote progression of disease and chronic coronary syndrome, which is beyond the scope of my talk today. But all that to say is that there's some rationale for using antiplatelet agents in chronic coronary syndrome as well as ACS, because you're not only trying to modulate acute thrombotic events, but also modulate the progression of atherosclerotic disease going forward. Obviously, there's a lot of different agents on here, but we'll be just focusing on aspirin as well as our most commonly used P2Y12 inhibitors with clopidogrel, prasugrel, and ticagrelor. So the major benefits of antiplatelet therapy, both during PCI as well as after PCI, are there's several. Their antiplatelet therapy reduces the risk of periprocedural thrombotic events, myocardial damage that can be associated with the catheter wiring, blood vessel wall trauma, dissections, plaque ruptures, or embolization that may occur during the procedure, or even if you have side branch occlusions, if you have a branch lesion. Post PCI, it reduces the risk of stent thrombosis, which is kind of what we'll be focusing on a little bit more, which is most commonly occurring in the acute or subacute phase after PCI. And our cornerstone strategy is DAPT, a dual antiplatelet strategy, maximizing the benefit of antiplatelet therapy by focusing on different mechanisms of the platelet aggregation and activation pathway, as I just kind of showed previously, where you combine aspirin and AP2Y12 inhibitor therapy, because there's been studies that show that there's a synergistic platelet inhibitory effect, which results in improved efficacy to prevent thrombosis. So this is a nice little illustration I found in a review paper that just kind of goes through some of the benefits of antiplatelet therapy, both during PCI as well as after. So, reducing thrombus burden and flow obstruction during the procedure when you're having acute plaque rupture, erosion, reducing periprocedural related damage. So if you have an iatrogenic dissection, if you have plaque disruption, side branch occlusion, things like that. So antiplatelet therapy can be beneficial in these circumstances as well. But we'll be focusing a little bit more on stent thrombosis and post-PCI complications. But this was a nice little illustration depicting that across the spectrum of both ACS as well as chronic coronary syndrome. This is another illustration from that same paper. And this slide is important because it's kind of emphasizing that, antiplatelet therapy beyond PCI can have varying benefits in terms of prevention of local ischemic events, preventing plaque progression and destabilization of other lesions, as well as preventing systemic ischemic events such as stroke or peripheral artery disease events. So there's a wide variety of post-PCI benefits as well associated with antiplatelet therapy. However, it's important to recognize that the potential benefit varies with time. And the greatest benefit that we typically see in terms of less ischemic events is usually maximized within the first few months after a PCI. So it's important to try to maximize those benefits while avoiding the bleeding risk complications, which are pretty stable risk over time. It's a slightly higher immediately, peri-procedurally, because of the risk of interventions and vascular trauma access, things like that. So as we know, bleeding is the major drawback for DAPT strategies and long DAPT strategies. It's associated with adverse prognosis, both from an all-cause standpoint as well as from a cardiovascular standpoint, for a variety of reasons. I mean, these patients can have major life-threatening bleeds, obviously, but there's also cardiovascular implications as well, where patients may stop their antiplatelet therapy sooner than anticipated, which can lead to more cardiovascular events and stent thrombosis. Bleeding can also cause inflammation and activation of coagulation pathways, as well as systemically in these patients, which can also raise their risk for cardiovascular events. And then blood transfusions. I mean, if these patients receive a blood transfusion, that can also promote a vasoconstrictive and platelet aggregation type scenario as well. So there's a lot of things linked. It's not just, these patients are having significant bleeds, but there's also other, implications from a pathophysiologic standpoint that can contribute to worsened prognosis. And as we know, the risk of bleeding is proportional to the intensity of antiplatelet therapy. So the more agents you have, obviously, the higher risk of bleeding. So what do our guidelines say? I'll briefly run through the ACC/AHA guidelines for DAPT duration after ACS, as well as the European guidelines, and I'll kind of talk about where this data comes from, like which trials it comes from. But as we know, they're not. Both sets of guidelines recommend a standard 12-month DAPT strategy for ACS, acute coronary syndrome patients following PCI with drug-eluting stent. And that's primarily to reduce the risk of MI and stent thrombosis. So this is the 2016, obviously, many years ago, but this is their update on their duration of DAPT for NSTEMI and STEMI patients. They give a class 1 recommendation for DAPT with aspirin or plus P2Y12 inhibitor, which could be clopidogrel, prasugrel, or ticagrelor. And it's interesting because in their wording, they actually say for at least 12 months. So they're offering the potential to extend therapy here. They also give a class 2B recommendation to consider de-escalation after 6 months to just aspirin monotherapy in patients who are high risk of bleeding or who suffer a major bleed. In 2021, there was an update to this to some extent in the ACC/AHA SKY guidelines for coronary revascularization, which maintained the class 1 indication for 12 months of DAPT with the same agents, but give a class 2A recommendation to discontinue aspirin maybe after 1 to 3 months of DAPT with continuing P2Y12 inhibitor therapy thereafter in certain patients who are high risk for bleeding. And then discontinuing P2Y12 inhibitor therapy after 6 months could be considered reasonable as a 2B recommendation in patients who are high risk of bleeding. But they didn't give explicit objective ways to categorize high risk of bleeding as compared to the European guidelines. So again, here, the European guidelines for the management of ACS do give a recommendation for in all patients with similar DAPT strategy, 12 months. But they do recognize that if there is a high bleeding risk, you can consider shortened therapies. They give a 2A recommendation for patients who, are event-free in terms of cardiovascular events after 3 to 6 months. You can de-escalate from DAPT strategy to just P2Y12 inhibitor monotherapy strategy. They also do give some guidance in terms of 2B recommendation to de-escalate in terms of intensity as well. So going from prasugrel or ticagrelor down to clopidogrel could be considered as an alternative DAPT strategy in combination with aspirin for patients who are high risk for bleeds. And then they also say that they give a 2B recommendation to continue aspirin or P2Y12 inhibitor monotherapy after just 1 month of DAPT in high bleeding risk patients, and that's a 2B recommendation. And they define high bleeding risk patients as patients who meet the ARC criteria. So that's the Academic Research Consortium on High Bleeding Risk. So the presence of 1 major or 2 minor criteria is a patient that, is high bleeding risk according to their guidelines. Obviously, a lot of these are, clinically intuitive, and, we can make these decisions without having to consult this, but it's nice to have some objective measures to kind of see which patients may be higher risk. And it's a lot of the things that you would expect: cirrhotic patients who are chronically anemic, kidney disease, patients who are on anticoagulation, things like that. So, but they are a little bit more explicit in terms of how they define some of these patients. So where does all these guideline data come from? And specifically, there were several, 4 major trials that we'll talk about. They're in the early 2000s, mid 2000s, that looked at DAPT therapy. The first is the CURE trial from 2001. It was looking at a DAPT strategy with aspirin and clopidogrel in patients with essentially NSTEMI ACS. And this had almost 13,000 patients. Patients were essentially randomized to a DAPT strategy in between months 3 to 12 versus just aspirin monotherapy alone. And they saw that there was a significant reduction in cardiovascular events in the DAPT strategy the longer that you extended out the DAPT up to till 12 months. Obviously, there were significantly more patients with major bleeding in this group as well, but there was that cardiovascular benefit and protection noted. The PCI CURE trial was another trial. It was almost 3,000 patients in 2001, kind of similar. This was patients that were essentially received DAPT with aspirin and clopidogrel for 1 month. And then after that, they essentially were either randomized to aspirin monotherapy for another 8 months versus clopidogrel DAPT strategy for 8 months. And they found that the DAPT strategy had better outcomes in terms of lower risk, lower cardiovascular death, myocardial infarction, target vessel revascularization, but more risk of bleeding. This is the TRITON-TIMI-38 trial. So this is a trial comparing prasugrel to clopidogrel. In a DAPT strategy. This was like almost 14,000 patients from 2007. And essentially they found that, the DAPT strategy with prasugrel as compared to the DAPT strategy, the standard DAPT strategy with clopidogrel, had significantly reduced rates of ischemic events. There was no difference in mortality, but there was less ischemic events in that 1 year with the DAPT with prasugrel strategy. And then the Plato trial compared Ticagrelor to clopidogrel in patients with acute coronary syndrome. This was STEMI and STEMI patients. And then they essentially found that Ticagrelor DAPT strategy, standard DAPT strategy, reduced the rate of cardiovascular events. And there wasn't a significantly higher rate of major bleeding in the Ticagrelor group, but there was an increase in the rate of non-procedure related bleeding. But these are the essential major trials that a lot of our guidelines draw from in terms of this standard 12-month DAPT duration. So it's important to just recognize those and the limitations of those as well. Those trials obviously are outdated. They don't account for all the advancements that I kind of mentioned previously in terms of our PCI techniques, drug-eluting stent technologies, the fact that we've had advancements in our antiplatelet therapy, we've had advancements in the way that we risk stratify and select some of our patients, as well as the fact that none of those trials looked at P2Y12 inhibitor monotherapy after short-term DAPT. They all looked at aspirin monotherapy. And we know that P2Y12 inhibitor therapies are arguably stronger antiplatelet agents as compared to aspirin. So there is newer data to suggest shorter durations of DAPT can give you that same cardiovascular benefit without getting that trade-off of higher risk of bleeding. So this is some of the data that kind of guided the leading up to the trial that I'll talk about today. This is a meta-analysis from 2023, so just a year ago. Included 32 randomized trials, and essentially looked at cardiovascular outcomes as well as bleeding outcomes across all of these trials, comparing various different durations of DAPT strategies as well as agents used in DAPT strategies as well as monotherapy thereafter. So they looked at standard DAPT with 12 months with clopidogrel, prasugrel, ticagrelor, or low-dose prasugrel. They also looked at extended DAPT duration, so greater than or equal to 18 months of DAPT. They looked at short-term DAPT, which was less than or equal to about 3 months for DAPT with a P2Y12 monotherapy thereafter, or even less than about 6 months or so of DAPT followed by aspirin monotherapy. So there was it was a very interesting meta-analysis that looked at these varying strategies and compared them all in terms of these outcomes to see. And there was as you can tell, in terms of major adverse cardiovascular events, there was no significant difference when you compared the short DAPT trials followed by P2Y12 mono inhibitor therapy thereafter. There was no statistically significant difference in terms of cardiovascular events, whether you used short-term DAPT followed by aspirin, whether you use standard DAPT, whether you use extended DAPT. But there was, as you would expect, a signal, although not statistically significant across the board, for lower bleeding risk with the shorter DAPT, as you would kind of expect. Then there was the TICO trial from a couple of years ago. This was where patients were randomized to receive a DAPT strategy for just 3 months, followed by ticagrelor monotherapy. As you would expect, the 12-month DAPT arm had more bleeding, and there was no statistically significant difference in terms of cardiovascular or cerebrovascular events between the two groups. And then there was the TPAS trial, which is interesting. This was a trial where patients had what they defined as very short DAPT duration. I think their median was about 16 days of DAPT or so, followed by ticagrelor monotherapy thereafter. This was an open-label non-inferiority trial, so there were some limitations there, but they found that there was, again, no significant difference in terms of cardiovascular outcomes between the extremely short DAPT duration as compared to standard DAPT duration, and there was a lot less bleeding, as you would expect. And then this was the Twilight trial looking at, again, ticagrelor monotherapy after just 3 months of DAPT, and it's kind of similar findings as the previous trials. So the trial that I'm talking about today is the ULTIMAR-DAPT trial. So this is a little bit different because it's going to be looking at 1 month of DAPT followed by ticagrelor monotherapy. But along the same lines, trying to beg the question: does a short course of DAPT followed by ticagrelor monotherapy alone, does that reduce the risk of clinically relevant bleeding without an accompanying increase in major adverse cardiovascular or cerebrovascular events? It was a multi-center trial. It was kind of like a two-part trial. As it was partnered with the IVUS ACS trial, which was a trial where essentially patients were presenting with acute coronary syndrome were randomized to receive PCI guided by IVUS versus angiography alone in terms of drug-eluting stent implantation to the culprit lesion that the operator felt was causing the acute coronary syndrome. And so the second part of that trial essentially was the ULTIMAR-DAPT trial. I'll kind of talk about that. It was conducted across primarily in Asia. Most sites were in China, which limits the generalizability, but also conducted in sites in Italy, Pakistan, and the UK. So we'll kind of go through it with a PICO format. So this is the population that they looked at. So they included patients older than 18 presenting with acute coronary syndromes, which included unstable angina in addition to NSTEMI and STEMI. They excluded patients who had a CABG previously, who had kidney disease, severe kidney disease, patients who may not be able to continue their antiplatelet therapy or had a recent stroke. So there were certain things that they did exclude here. And they also excluded patients who were going to be on oral anticoagulation as well for any other indication. So these are some of the baseline characteristics of their patients in both arms. So the median age is around 62, is predominantly men, about 75%. It was almost 85 to 90% Chinese patients. About 40% of the patients presented with unstable angina. And then in terms of comorbidities, kind of the run-of-the-mill things that you would expect to see: hypertension, diabetes. About 10% of the patients, respectively, had a prior PCI or prior MI or stroke. So patients with a significant portion of patients with underlying cardiovascular disease. And I'll skip that. So essentially the way this worked was, as I mentioned, the IVUS ACS trial, patients were initially randomized on presentation with acute coronary syndromes to receive PCI either with IVUS guided or angiography alone guided at day one. And then essentially were treated with DAPT, with aspirin and ticagrelor for 1 month. And then at 1 month, these patients, again, were randomized to either ticagrelor and placebo versus ticagrelor and aspirin for the subsequent next 11 months to complete their therapy. So in terms of total patients, they had 3,500 patients or so initially that, about half were randomized to each IVUS guided or angiography guided PCI. Ultimately, at second randomization, they ended up with 1,700 patients in both arms with DAPT as compared to ticagrelor monotherapy arm. In terms of follow-up, they had excellent retention. I mean, they only had 1 patient lost to follow-up in one arm. So overall, 1,699 patients in one arm and 1,700 patients in the other. The primary outcomes that they looked at were the superiority endpoint that they used was they defined clinically relevant bleeding as based on criteria laid out by the Bleeding Academic Research Consortium, or the BARC, types 2, 3, or 5, and I'll talk about what those types are. Their non-inferiority endpoint was looking at major adverse cardiovascular or cerebrovascular events. They also included several secondary endpoints. I didn't list all of them here, but they looked at time to first occurrence of a net adverse clinical event. They looked at target vessel failure, non-fatal MI, stent thrombosis. They also looked at other, bleeding outcomes as well, as defined by different guidelines and in terms of like the Gusto, TIMI scores, ISTH. So I didn't include all those here, but so this is the definitions that they used to define clinically relevant bleeding. They looked at types 2, 3, and 5. Type 2 was kind of maybe considered more so on the mild to moderate side of bleeding in terms of these are patients that were not having a bleed that requires, non-surgical or surgical intervention, but does require medical intervention by a healthcare professional that may end up in the patient getting hospitalized. Whereas types 3 and 5, you can see is pretty significant bleeding, of dramatic drop in your hemoglobin, intracranial hemorrhage, borderline fatal bleeding. So those types of bleeds. So there is a little bit of a spectrum in terms of the bleeding outcomes that they included here, but I think it was useful to at least see what definitions they used here. And these are their outcomes here. So on the left here, you have your bleeding outcomes, your clinically relevant bleeding. So you can see here that the DAPT, the longer duration DAPT group, had statistically significantly more bleeding, clinically relevant bleeding, and there was no significant difference in terms of their major adverse cardiovascular or cerebrovascular events that extended out till 12 months follow-up, essentially. And when you look at this across their pre-specified subgroups in terms of age, race, gender, comorbidities, things like that, there was a trend towards, lower risk of bleeding in the patients that had the shorter DAPT duration, as you would expect, albeit not statistically significant, but there was a signal there. And then there was no, profound signal for a significant difference in terms of cardiovascular outcomes between the two arms across all these pre-specified subgroups. Interesting to note in their secondary endpoints, I did mention this earlier, that they had other types of bleeding, major, minor bleeding as defined by TIMI or Gusto or ISTH guidelines, and essentially there was statistically significantly less bleeding across the board with the shorter DAPT duration arm. In terms of ischemic events and ischemic secondary endpoints, there was no significant difference in terms of mortality, cardiac death, stroke, MI between these two patients. Obviously, this trial, as every trial, has its limitations. One of the things that's worth noting is that their clinically relevant bleeding was defined as BARC type 2, 3, and 5. So type 2, you could argue, is not as clinically significant bleeding, but still, I think it's still worthwhile to include those patients because, if this strategy can reduce even minor bleeding, I still think that's beneficial for a lot of our patients. But a lot of other trials kind of looked at more severe hemorrhage, life-threatening hemorrhages, but still, it's still important nonetheless. They used a kind of a wide margin for non-inferiority for the major adverse cardiovascular, cerebrovascular events, and it turned out to be a little wide because of their they had a lower anticipated rate of ischemic events in the DAPT arm. Additionally, a lot of these patients did have unstable angina, about 40% of them. So, it's not all purely STEMI patients, but at the same time, this was conducted in China and Pakistan, where places, a lot of these hospitals didn't have high sensitivity troponins. And although their lab troponin was negative, it's very possible that maybe they were presenting with an NSTEMI type picture. Obviously, this study doesn't inform us much. It doesn't inform us at all about the utility of even shorter DAPT duration or antiplatelet regimens beyond 12 months. And then there's limited generalizability because a lot of the patients were from China. A lot of the patients, we're not able to extrapolate these findings to a lot of the patients that were excluded that we commonly encounter in our clinical practice, such as CABG patients, patients who have complex, coronary disease. So obviously there's some limited generalizability there. But I do think it's a useful trial. It's very informative. It's kind of reinforcing what we were seeing with the TICO, the TPAS, the Twilight trials, the meta-analysis. And hopefully it's going to signal a shift in our guidelines and our clinical practice going forward to tailoring, shorter duration of DAPT after ACS, in order to optimize cardiovascular outcomes while limiting the risk of bleeding. But obviously, there's a lot of things that we need to ask ourselves. Is this going to extend to other P2Y12 inhibitors such as prasugrel and more importantly, clopidogrel? Because Clopidogrel is a cheaper drug. It's easily more accessible to a lot of our patients. But obviously, there's the question of Plavix responsiveness. And is there any utility in assessing that, going forward before starting that for patients? Is there any utility in shortening DAPT duration even further? I mean, we saw that in the TPAS trial, just 16 days of DAPT followed by Ticagrelor seemed to be okay. I don't know if 16 days versus 30 days is going to offer that much benefit from a bleeding standpoint, but it's something to consider. They excluded in this trial patients who are on anticoagulation for any kind of indication. So obviously there's the whole question of triple therapy. How are you supposed to address that? What's the optimal duration, time period? So we need some more data to help guide that for those patient populations as well. And then obviously our other coronary disease patients who had CABG, complex PCI, patients who had significant left main disease. How do these findings and cardiovascular protection with short DAPT relate to them? And then, some of the trials that I mentioned did include patients with stable angina, but overall, we're going to need some more data to kind of help, shorten our DAPT durations potentially for patients who get PCI for stable angina. That's refractory to medical management as well. So these are some of the big things I think that we can take away from this trial, and hopefully it's practice changing.
Thank you, Muz. Very good review of an important trial. You're right. I mean, I'll just open. We're just any quick comments, questions about this trial from the audience. I mean, I was just going to say, you sort of touched on it, whether this is a promotion of Ticagrelor monotherapy versus like how much of the positive result was due to that Ticagrelor may end up being just a really good monotherapy drug versus, improvement in stent technology and deployment techniques and, skill and of operators making this possible. It's hard to tease out, these results in terms of just being able to be on monotherapy so quickly, which, back in the old days would have been unthinkable. It'll be interesting to find out how this changes practice moving forward. So,
yeah.
All right. Well, very good.
Cool.
Thank you.
Thank
We'll
you.
move on to our thanks again, Muz. We'll move on to our second speaker, which is Dr. Andrew Murphy, who is going to talk to us. Dr. Murphy, also a second-year fellow in the clinical track, came here from the University of Pittsburgh Medical Center, and he is going to talk to us about, the ATTRibute trial. So, Dr. Murphy.
Great. Thanks, Dr. Williams. Yep. So today, talk about an exciting trial, came out in January, called the ATTRibute-CM trial about Acoramidis, called the Efficacy and Safety of Acoramidis and Transthyretin Amyloid Cardiomyopathy. So just a little bit in the way of background. I don't have any disclosures. In the way of background, transthyretin amyloid cardiomyopathy. So the protein is a 127 amino acid protein from the liver, transports thyroxine and vitamin A. So fibrillogenesis, kind of pictured down here, occurs when these tetramers dissolve into monomers, which are less stable, and then form these fibrils that then deposit in the myocardium. This results in heart failure and arrhythmias. I think we're all pretty generally familiar with this concept, and oftentimes there are delays in diagnosis, although it's being increasingly recognized as a disease process to be aware of. There is the wild type or senile amyloidosis, and then there is mutant amyloidosis with over 120 pathogenic mutations in the gene. There is a few that cause a plurality of the cases that were looked at in the current study. So just a little bit more about the pathogenesis. There are certain variants that are a little bit less stable, so that degrade from the tetramers to the monomers and cause the fibrils, that have earlier disease onset, increased genetic penetrance, and then worsens clinical severity. So for over a decade, the clinical goal has been to stabilize the tetramers to prevent them from going to the monomers and causing the fibrils. So this is what tafamidis does. And the name of that trial in 2018 was the ATTRACT trial. It showed a lower risk of death, which is important to contrast here, and then lower risk of cardiovascular hospitalization, lower functional decline in 6-minute walk time distance, and then Kansas City Cardiomyopathy Questionnaire, all over 30 months, and then continued to show a reduction in all-cause mortality at 58 months in the follow-up trial. So that was back in 2018. So just a little bit about Acoramidis. It is this drug that was initially designed by this company called Eidos, and then that was bought by BridgeBio. It's a Stanford-associated clinical biopharmaceutical company, and they've been, I'll talk about it a little bit later, but they've been excited about this drug for a long time. The name for it was AG10, and basically what it does is it simulates this mutation, the T19M, 119M mutation that causes higher tetramer stability with hydrogen bonds. It kind of goes into this bind pocket right here. So AG10 simulates this variant in the TTR gene and increases stability of the tetramers in both wild type and genetic mutants, which is really important in terms of the cardiac amyloidosis population that this would be potentially able to help. So then in phase 2 trials and in vitro trials, it showed increased potency, binding affinity, binding site occupancy, TTR stabilization compared to tafamidis, and then some other therapies that I've heard a little bit less about, difluzinol and tolcapone. However, as we all know, tafamidis is $225,000 a year therapy, so obviously cost prohibitive for many patients. And then this is just a quick excerpt from one of the poster presentations that they had about AG10, that in vitro incubation of tafamidis alone did not entirely stabilize TTR at normal therapeutically attained plasma concentrations, but when combined with tafamidis in vitro, complete stabilization of tetrameric TTR was achieved. It was also noted to be have a binding strength more than 3 times that of tafamidis and more stable than tafamidis in vitro. So kind of bringing us to the present trial. So this was a phase 3 clinical trial to look specifically at Acoramidis and get some clinical data. So it included patients ages 18 and 90 years old who had TTR amyloid cardiomyopathy. They could be biopsy positive or have a positive PYP scan after AL amyloidosis was excluded. This is important in contrast to the ATTRACT trial with tafamidis, which only included biopsy-positive patients. They also had to have at least one, they had to have clinical heart failure with at least one hospitalization, signs of symptoms or volume overload, or needed diuretic. They had to be sick, but not too sick. So NT-proBNP of 300 or more, and then had a 6-minute walk time distance of more than 150 meters with some LV hypertrophy. In terms of exclusion criteria, this is the not too sick. They couldn't have had recent ACS, revascularization, stroke. They couldn't be likely to receive a heart transplant. They obviously couldn't have AL amyloidosis. This is just for TTR. They couldn't have more than moderate hepatic impairments because these patients weren't studied for any of the earlier trials. And they couldn't have an NT-proBNP greater than 8,500 or be ESRD CKD5. Then importantly, tafamidis co-treatment was not permitted during the initial 12 months of the trial. However, it was allowed after the initial 12 months of the trial, which I'll talk about a little bit more later. So in terms of the methods, patients were randomized in a 2-to-1 ratio for Acoramidis 800 milligrams BID versus placebo. There were 3 different variables by which they were stratified. Their genotype, NT-proBNP level less than or more than 3,000, and then GFR less than or more than 45. These latter 2 groups, kind of what this bullet point is saying, are meant to mirror the National Amyloidosis Center criteria. There's stage 1, 2, and 3. If both of these variables, if you have eGFR less than 45 or an NT-proBNP greater than 3,000, that is stage 3. If they're both if you have NT-proBNP less than 3,000, eGFR greater than 45, that's stage 1, and then any other combination is stage 2. And then stage 4 CKD patients were excluded from the primary efficacy, but were included in the safety analysis. So this is another reason I wanted to talk about this trial. It had a pretty interesting outcome that they looked at called the hierarchical win ratio that included a modified intention to treat population. So they were included in the analysis if they were randomized, received at least 1 dose of the med, and then had at least 1 efficacy evaluation after baseline. So the 6-minute walk test and so on. So for the win ratio, as a brief aside, MACE or an equivalent has been used, especially in cardiology trials, for decades, and there are some qualms, especially in the statistics community, about the use of this as an outcome for a primary outcome for a trial. With the major issue being that especially if it's a composite outcome, what you're looking at is the time to the first event, whatever that event may be, which is problematic in that it places equal weight on each component that's included in the composite outcome, whether it be death, hospitalization, and then I list a couple others there, hospitalization, bleeding, stroke, MI, revascularization. But the issue is that obviously like that's equating many different things that are not of the same clinical magnitude. And then first events are often clinically less important. You're more likely to have a heart failure hospitalization before you have a hospitalization that leads to death. And so in effect, non-fatal events are prioritized more highly than non-fatal events that would occur later for a given population and survival analysis. So the hierarchical win ratio is designed to kind of treat this. And this was actually the same analysis that was used in the tafamidis trial. But essentially what you do is it prioritizes the importance of whichever variable you'd like to be highest prioritized, typically mortality, but can also address variables of morbidity and function. So things like hospitalization and things like quality of life questionnaires. All possible outcome or all possible comparisons are only made at the first step, and then ties are subject to the remaining comparisons. And I'll have a flow chart that I'll show a little bit later to make that a little bit more clear. So at the very top of the hierarchy, that's where most of the comparison, or ideally most of the comparison is done, and then only ties are subjected to further comparison. And you can have, I guess, as many events as you'd like going down to kind of suss out whether the test measure or the placebo is more effective. And then there's a couple other advantages. You're able to account for repeat events with hospitalization, such as heart failure admission being a really commonly used application for this. So in terms of the trial for the primary outcome here for the win ratio, it was stratified across 3 dimensions, like I said. So genotype, wild type versus variant, NT-proBNP more than or less than 3,000, and then EGFR less than or more than 45. So in order, they stratified, or they looked at death from any cause, and death also included heart transplant or VAD implant. If both pairs were deceased, it looked at the survival time and granted the win to the patient with the higher survival time. It looked at cumulative frequency of cardiovascular hospitalization, so not all-cause hospitalization, but rather just cardiovascular adjudicated hospitalization, change from baseline NT-proBNP level, change from baseline 6-minute walk time distance. Within each stratum, all patient pairs were compared in the same hierarchical sequence. So if you can imagine, within each strata, and there are 8 different strata, 2 times 2 times 2, across those 3 variables, every single pair was compared between Acoramidis and placebo, every single possible pair. All of those wins and losses were counted and tallied up and then compared against the 2. And that generates a win ratio, which is the proportion of comparisons for which treatment wins over placebo, divided by the proportion of which placebo wins over treatment. So this is the flow chart. So after you have all the patients in each strata, compares every single patient possible pair is compared. So you have treatment versus placebo. First go to all-cause mortality. If one patient died and the other didn't, then obviously that's a win for the study drug or win for placebo. If one lives longer, then that's the win. If it's a tie, proceeded along to frequency of cardiovascular-related hospitalization. If those also tied, then it went to difference in NT-proBNP. It had to be a margin greater than 500. And then obviously the positive change was the one that won in that comparison. And then it was changed from baseline and 6-minute walk test. Looking through the appendix and this trial, I believe it's just whichever one had the farthest distance. I don't think there was a margin between the 2 that was required. So literally if one person walked 1 meter farther than another person, then that was considered a clinical win. So secondary outcomes that were looked at in this trial are all just the individual components that were used to make the hierarchical win ratio with the addition of the Kansas City Cardiomyopathy questionnaire. And they looked at all of those individually. Interestingly, for this trial, this there was a lot of scrutiny, and there was a planned 12-month readout for the trial, which ended up being not favorable for the drug. The analysis was still meant to be carried on until 30 months, and everything remained blinded until that 30-month period. But they had a readout of the 6-minute walk time distance and the Kansas City Cardiomyopathy questionnaire. It was actually worse for the 6-minute walk time distance, and then slightly better for the questionnaire. You can see that these are both decreases in the distance, but the decrease for the study drug was worse than the placebo. The questionnaire was a slightly better decrease compared to placebo, but then neither of these were significant statistically. And then, like I said, analysis continued until the end of the 30-month period. There was a lot of, just reading between the lines, a lot of panic after this 12-month readout happened. So they actually completely changed their methods. Initially, the win ratio is just going to look at mortality and cardiovascular hospitalization. But because of their preliminary findings, including these two variables, they actually thought that it was going to be underpowered to detect a difference for either of the two variables. So then they added on 6-minute walk time distance and NT-proBNP to the win ratio to increase the likelihood that they detect a difference between the two groups, which is obviously not what they set it out to do initially. So in terms of the results, they recruited from April 2019 to October 2020. There were 632 patients randomized in a 2-to-1 ratio. 21 patients had CKD4, so they were included in the safety, but not efficacy analysis. So there were 611 patients total randomized to the efficacy analysis, 409 to 202. Just a quick look at some of the demographics. Clearly a majority of male patients, white patients, and then vast majority, 90% basically for each group, had wild type TTR. And then the plurality of mutant TTR patients were the valine 122 isoleucine amino acid mutation subset. And then in terms of clinical characteristics, as you can see here, the majority was NAC, National Amyloidosis Center, stage 1, and then MYHA2. NT-proBNP was about 2,800. So in terms of the primary outcome, they show here what their true primary outcome was on the top row here, and the 2 rows below it are the 2 prior iterations, and it was positive. So it had a win ratio of 1.8, meaning that there were 1.8 times the number wins times the number of losses, and that was statistically significant. Kind of interestingly, just kind of by the skin of their teeth, it was also positive with the initial outcome that they were going to look at, and then the intermediate that just included 6-minute walk distance, but not NT-proBNP, was still significant, but again, clearly not by much. And so just a different way of visualizing this, because I do think that we will see win ratio more and more, especially in cardiovascular trials, and so it's important to kind of understand and visualize. So of all patient pairs that were examined, there was some difference for mortality for about 29%. So 15% of those were wins for Acoramidis, 13% of those were losses for Acoramidis, and then the rest were ties. So then for that, just for this 70% that didn't win or lose for the ties, you proceed along to the next step, which is frequency of cardiovascular related hospitalization. So you'll note that these 3% percentages here add up to 71.2%. They don't add up to 100. So just looking at cardiovascular related hospitalization, there were 19 compared to 10% wins and losses respectively for Acoramidis. And then you proceed along to the next step for these 42% ties. So then you'll notice again that these 3 percentages add up to 42% for the change in baseline NT-proBNP. And if you'll remember, they had to have a margin greater than 500 for a win or a loss. So the ones that were within 500 were considered ties and then passed along to 6-minute walk time distance. So that left with the remaining percentage of patients. There were still 0.3% ties at the conclusion of the study. And then very simply, this number is divided by this number to get your win ratio. NT-proBNP had the greatest marginal number of potential ties that were broken, which I think is kind of interesting here. And then NT-proBNP had the highest ratio of wins to losses. So this number was the highest ratio compared to this number of any other level. In terms of the pre-specified secondary results, this is just all those other variables that were considered as part of the primary outcome. So in terms of cardiovascular hospitalization, it was significantly improved with a relative risk ratio of 0.496. That was significant. This is a graph of the change in NT-proBNP level. You can see with placebo, it got markedly higher. Since randomization, Acoramidis got a little bit higher. The 6-minute walk time distance, they both decreased, but Acoramidis decreased a little bit slower than placebo did. The change in the KCCQ, Acoramidis had a decrease, but was a lower decrease compared to placebo. I include here as well. So for tafamidis, for the ATTRACT trial, there actually was a more significant delta. There was a better improvement in the KCCQ cardiomyopathy questionnaire for tafamidis compared to Acoramidis. And I neglected to mention, but the same thing for the 6-minute walk distance, that there was a 40-meter difference for Acoramidis versus the 75-meter for tafamidis. And then finally, the change in serum transthyretin level. So you want a higher level. This is the amount of the tetramers that are found in serum. So this indicates clinical stability of those tetramers. The higher this level is compared to placebo, so clearly higher. And this was not something that was looked at in the tafamidis trial. So this is also an important slide that showed that there was not a mortality difference when looked at alone outside of the pre-specified primary outcome, that they started to diverge a little bit after 18 months, after they crossed several times before then. And there was a trend towards benefit for Acoramidis in terms of mortality versus placebo, but it was not statistically significant. So the authors had a couple of takes on this, noting that tafamidis did show lower all-cause mortality with a hazard ratio of 0.7. They thought that this was probably due to a couple things: evolution in disease awareness, possibly earlier diagnosis, maybe increased use of a non-invasive diagnostic algorithm rather than just relying on biopsy alone, and then overall maybe better management of the heart failure population. And then another kind of problematic issue that I mentioned before is that there was tafamidis use for many of these patients that were in the trial receiving Acoramidis. So about 20% of patients overall received tafamidis. They weren't allowed to take it for the first year of the study, but from months 13 to 30, they were clinically able to take tafamidis, and ended up being a slightly higher percentage in the placebo group compared to the treatment group. In terms of safety outcomes, overall incidence of adverse events was acceptable for the treatment versus placebo group, and same thing with serious adverse events. Limitations for the trial, major ones that I mentioned already: the primary analysis was changed from just the 2-component win ratio ultimately to the 3, and then to the 4-component hierarchical win ratio, which obviously shows a pretty big slide in terms of what they set out to look for and compare, and what they ultimately compared. There was a lower than expected amount of cardiovascular hospitalization at 12-month readout that led to that. The addition of those 2 components, it was a pretty homogeneous population, as I mentioned earlier, and then there's concomitant use of tafamidis. So in terms of the summary for this trial, in this randomized, double-blind, placebo-controlled phase 3 clinical trial in a population of mostly older white male patients with mostly wild-type TTR cardiac amyloidosis and nearly 20% concomitant tafamidis use, Acoramidis resulted in a significantly higher win ratio of 1.8 that considered in order mortality, cardiovascular hospitalization, NT-proBNP, and 6-minute walk time distance. There was no significant mortality difference at 30 months for the reasons that were previously mentioned, but then all other pre-specified secondary outcomes did show a significant improvement, and there's a similar incidence of adverse events. And this was a slide that I was really hoping I would have time to get to. I'm not as avid of a day trader as my co-fellow, Dr. Peyton Hansen, but I did look briefly at the share price for BridgeBio, the company that owns Acoramidis. And just kind of interestingly, you can map it out. This is just over the past few years. Eidos was the company that initially was designing AG10 Acoramidis. BridgeBio buys or merges with Eidos. Stock price soars. they announced that the results of this 12-month readout, stock price crashes at the same time that this happens, kind of chugging along, and then they do a bunch of press releases for the positive results of the 30-month readout of data. And then what I take this kind of last little undulation for, and this is a huge, like, billion-dollar company that makes many different drugs. Like, this is not the only drug that they make, but clearly has a huge impact on the outlook for them. What I think is so interesting is this undulation here represents how, okay, the win ratio was positive, but what does a win ratio really mean? And how do I clinically contextualize what that number of 1.8 actually means in my practice? And I think that's kind of what this up and down means at the end. And these are my references.
All right, thanks, Andrew. Very good. Time for a couple questions from the audience.
Hi, hey, Andrew, it's Mariana. Great talk. Just quick question. Any insight or discussion on the cost of this? I presume it's going to be prohibitive, like tafamidis.
So the writing on the wall is that and this is not in the article itself. I just kind of went down a little rabbit hole, like Business Insider and just random like finance news pages. The writing on the wall is that it's supposed to be a cost competitor for tafamidis. Tafamidis makes $3.3 billion yearly for Pfizer. And so this has been, for over a decade, recognized as a niche for some company to kind of jump in there and make a price competitor for. The goal for each of these companies has been to make something that'll drive the price down and ultimately should be good for the patient, because tafamidis obviously would potentially have to be made a little bit more affordable if there's a competitor in the same space. The drug has been submitted to the FDA and they're expected to make a decision for it by November. So there should be an answer by the end of the year. But that's kind of like throughout all of this, that's what the goal has been, is to have a less cost prohibitive TTR stabilizer.
So this is Neil Dickert. So thanks for a really great presentation. I just want to commend you on sort of going through the win ratio, which, as you say, is a complex, not straightforward to think through, but really important in thinking about how to deal with components of composite endpoints which are not the same. And we've seen this in a number of cases in cardiovascular disease where trials have been considered victories based on what many would say are sort of arbitrary components or less important components of composite endpoints. A really nice way to talk through that. With regard to the last piece, to tag onto Mariana's question just a little bit, one, I did have a question for you. I look back to, I was curious about the tafamidis sort of co-administration piece. My understanding was that this was allowed after the trial had been going on for 12 months and not that the patients were able to take it after 12 months. So I thought what happened was it became considered non-viable to have patients who were excluded from tafamidis. But so that's a question for you. The second piece is that with regard to affordability, there's a big change about to happen, which is the cap on Medicare, on patients covered by Medicare Part D, which almost everyone with amyloid is. Where it's capped at $2,000 of out-of-pocket costs. So many people think these drugs have the potential to basically bankrupt Medicare Part D, but they're going to make it much more affordable for everybody in that population. The complicating factor is what you see here, which is that it means that amyloid drugs are no longer, placebo-controlled trials in amyloid are no longer going to be doable, in part because the only reason they were doable after tafamidis was approved was because a substantial portion of patients didn't have access to them because of cost. So it's becoming, I've talked with Kunal a little bit about this, and it's certainly an interesting sort of wrinkle in terms of trying to enroll patients in amyloid trials. The cost issue, which has previously been a major barrier, is the landscape's changing a little bit. And from a design perspective, what it means is sample sizes that are going to be necessary to study new amyloid drugs are going to be radically inflated because they have to be compared against an active comparator rather than placebo. So sorry for the long-winded comment, but maybe one question, the question really is it the case that people could take tafamidis after 12 months, or was it that after 12 months of the trial, it became allowed to have co-administration of tafamidis? My interpretation was
Hey, Neil, I can answer that question. Hey, guys,
Yeah.
this is Kunal. We participated in this study, and it was, Andrew, you did a good job of presenting it, and thank you for presenting this trial, which I think is going to be an important new drug in the landscape of TTR amyloid therapeutics. So, Neil, it was that after the patients were randomized, when they hit their 12-month follow-up visit, they now could go on tafamidis. So it wasn't the trial, it was the patient randomization.
Got it.
So of those patients that we enrolled, both ended up on tafamidis. And what's interesting is that when this drug, tafamidis got released May of 2019, and this study was just getting started around that time. And we had expected at Emory to be one of the higher enrollers in this study, but it turned out that when tafamidis got approved, their patient assistance programs were so aggressive that basically all of our patients qualified for tafamidis. I mean, it was all but 2 that ended up going into this study. I think the problem is going to be that, yes, Medicare may go bankrupt. There was a good presentation at ACC that showed that in the first 24 months after tafamidis was approved by the FDA, Medicare spent $1.8 billion on tafamidis prescriptions alone around the country. And those are, they also showed that geographically, those were mostly in the northern and western states that prescriptions were the highest in those areas where densely populated population exists. I think, this drug is going to be, I hope, approved by the FDA. This trial initially was thought to be a negative trial when they first released their 6-minute walk test data, which again shows you that that's probably not a good surrogate marker to assess this very sick patient population. But nonetheless, I think the hope was that at the 30-month mark that they would still have a positive result, which they did. And I've seen now reports that this drug is it's thought to be a better stabilizer than tafamidis, and they have data. The company has data which they presented to me individually at ACC that seems to be a better stabilizer for our hereditary V142I patients than the wild type patients, and they have some internal data to show that. So, I mean, I think it's going to be a legitimate second drug in this group of patients. Now, what's interesting is that there's also like 5 other therapeutics that are currently on trial, 2 of which we're going to be participating in with a CRISPR-Cas9 study and a depleter study, which essentially chelates the amyloid fibrils. So, I mean, there's a lot in this space that's going on, but this is hopefully going to be the new FDA-approved drug for cardiomyopathy, since we only have one drug, which is tafamidis, and hopefully eventually it doesn't bankrupt Medicare.
Well, thank you, everybody. I see there is folks with their hands up, but it is 8:35. So sorry to cut the discussion short, but thanks again to Dr. Murphy, Dr. Khawaja for their fantastic reviews, and thanks everybody for tuning in, and we'll see everybody next week.
The preceding program is copyrighted by Emory University.